Just a reminder that the meeting is being recorded. Everything that is said as part of this meeting or in the recording online is included in the publicly posted video on the Bureau's website. Thank you. We will go ahead and do roll call quickly. Amber Wright.
Present.
Dan Spate.
Dan Spade here.
Thank you, Dan. Ronzo Casterman. Absent. Frank Walter.
Here.
Leah Bradley. Present. Eve Godstinker.
Present.
Jason Johnson. Joshua Gaither.
Here.
Billy Augustine. Not available. Kevin Foster. Phoebe Merrill.
Yep, I'm here on mine.
We have an 8 back here. Thank you very much. I wanted to go ahead and just at the start of the meeting, take a moment of silence to honor the 2 unfortunate line of death duty from timber maintenance fire from earlier this week, along with the 4 individuals who were involved in the air medical crash last month up in northern Arizona as well. Thank you. Next, I would like to welcome Dr. Phoebe Merrill to MDC. So a big thank you. We have had an opening for this part of the state for quite some time. So welcome, Dr. Merrill, who is now officially the Watkins representative from EMS Council as a position serving on MDC. So I'm really happy to have that portion of the state represented. So welcome to the commission. We have the 2 vacancies now, or I'm sorry, 1 vacancy, a physician specializes in severe acute head injury treatment or spinal cord care, demonstrated interest or expertise in EMS. If you know anyone that fits that description and is interested in that role, they can apply with the Governor's Board and Commission website, which is linked on the agenda as well. Just a reminder from the attendance perspective, if you miss 2 or more consecutive meetings, the Bureau will reach out to you to see if you are still interested in participating on this commission. Our 2026 meeting schedule is attached. We did do our best to avoid any large conferences. So hopefully, if possible, we will avoid any, but I apologize if anything was fine. So we do our best. Next for Bureau report, that is linked in your packet as well. Nicole Witt is not available. She is doing her civic duty and is on jury duty, so she is not able to join us here today. So I will be doing the Bureau report. The Bureau chief position is still vacant. Just a reminder, we no longer have dedicated floor office space. So if you have any in-person business that you would like to do with the Bureau that does require an appointment, that can be made by email or by telephone. So we do sometimes get people that like to come in person to drop off applications or inquire about questions. That does need to be done with an appointment. We want to make sure that information was available. For the medical director, it's just kind of a reminder, we are seeing an uptick in EMTs who are working with expired certifications. This seems to have really increased in the past year. So just work with your agencies and try to make sure that they are tracking their personnel certifications. Comment center site reviewers, anyone who's involved in that process, I think has been communicated this very clearly. We are quite excited that the strategic plan that many of you were involved in developing and working on has been approved by the governor's office and is now live on our website. We have some dashboards that have also gone live. One of which is the EMS data dashboard for 2024. If we can click on that quickly, Russell did a really nice presentation for our last 2 meetings, going over all the updated data that is on here. So this includes all updated 2024 EMS data. And if we can go to, there we go, just quickly scroll through that. I wanted to just kind of demonstrate all the information that is available. As usual with the dashboards, you can click on different areas that will then adjust your data elements as you want to gather further information about that. EMS, pardon? Back to the, yeah, thank you. EMS for children, this has not yet been updated. We do have a new EMS for children coordinator. Welcome Savannah to the Bureau. Naloxone Leave Behind, a big thank you for everyone who is part of the Naloxone Leave Behind program. We have 66 agencies in the state. If we can open that map, this is a nice kind of demonstration of the agencies across the state. This was something what we realized we have a really nice combination about 50-50 urban and rural. And you can see the state is very well represented with agencies doing Naloxone Leave Behind. We have about 4,600 EMCTs trained and just under 1,900 kits that have been scanned out and given to the community. Our next really big announcement is the transition and publication of our share dashboard, which is our cardiac arrest dashboard. So this has been a really huge undertaking by our team here at the S Bureau, as our team took over the hospital side of the database. And then had been working on doing some data modernization, aligning our data elements with the National CARES database, and then really working and building the data dashboard. So this went live this week. There's both 2023 and 2024 cardiac arrest data. If we can click on that dashboard, I just want to highlight this for our committee as well. The agency specific reports, those are in progress. We are hoping to have those out soon. We're going to do a few test runs to make sure that everything is working well with this. But I did really just want to take a couple minutes just to go through this quickly with this group. You can see here that the total of just under 12,000 cardiac arrest patients. Off to the right is the number of excluded cases. So this is an obvious step is excluded DNR. And then we have just under 300 cases where there was a disposition unclear. So that takes the numbers down to 7,340, which is our share population. Of those numbers, we had 4,500 that were transported to the hospital and about 2,700 that had termination of resuscitation on scene. And then 77% of transported cardiac arrests are transported to a cardiac receiving center. One of the pieces that we are really going to work on is increasing our outcome data. So you see currently we only have data outcome from 57% of patients who went to cardiac receiving centers. Now with our data conversion and platform, we anticipate that we will have much higher percentages moving forward. Fortunately, many EMS agencies in their ETCR do document the outcome. So even if they were taken to a non-CRC or we didn't have the actual hospital data, we were still able to get outcome on about an additional 700 patients. And that takes our overall share population with outcome to 5,500. Next page. So this shows the EMS agencies participating in shares. So we have 152 agencies. The hospitals participating is 42. It shows our population there. And then it shows things that you can highlight data based on the its team population or all patients. Next slide. So this gets into some age, gender, specific and county specific data elements. I'm going to just fill Shelley's mouse here a little bit and show you how you can click on data to adjust this here. No. Oh, sorry. So just say we say, okay, we want to look at Maricopa County. So you click on that and you start to see different data elements. If you go, I want to look here. Adjusting right now, there might be a little bit of a lag. As a field characteristics, this I think is really a great visual representation. So this demonstrates some kind of opportunities for the more kind of prevention strategies. We see 37% of the time bystander CPR is performed. When you look at our data, so unwitnessed is 58%, witnessed by bystanders 31%, and EMS witness is 11%. So kind of looking at what percent of patients have a witness. Median EMS response time in minutes is 7 minutes. 23% had sustained rot. And then when you look at bystander AED applied, we're at about 7.5% of the state. So kind of looking at where opportunities for us to potentially improve survival from cardiac arrest, I really looked at bystander CPR, trying to increase those numbers and also increase the availability of AEDs out in the community. The final outcome, so this kind of shows you what is the outcome based on different elements here. So we look and say, okay, this patient had EMS, so overall survival is 5.9%. If we say EMS witnessed, that goes up to 10.7%. If we say unwitnessed, it's down to 2.7%. So we got our its population. You can see so patients with shockable rhythm, we have a much higher survival, up to 23%. And then this is something that we're going to actually update. Also was able to actually projected data. So our response times, we looked at survival based on response times. So if you go 0 to 4 minutes, 6.8 survived. 5 to 10 minutes goes to 5.9. 11.5, it goes down to 4.6. So a request we had in our first committee this morning from the staff was they said, can we break down this 5 to 10 minutes further? And so she was actually able to break this down into different elements. So she broke it into 0 to 4 minutes, 5 to 8 minutes, 9 to 12 minutes, 13 to 15. And what we saw was when you go past the 8-minute mark, the survival rate went down several percentage points. So she is going to get that updated on the website as well. But really wanted to point out to the Medical Direction Commission, the share dashboard, and that fact that it is live. So really excited to see that. Any questions at all about share and the dashboard?
It's been 20 years of share.
Yes, 12.
Yeah.
20 years. Thank you. So new dashboard to recognize 20 years. So Amber, go ahead.
Thank you, Gail. This looks really, really super amazing. I'm very, very impressed. I had one question about, you said you got some extra data from somewhere, some extra outcomes, and I didn't hear where you said you got the extra additional outcomes from.
Yes, let me scroll back to this one, which is kind of the general. Sorry, I'm having mouse issues here. All right, so I think when you go to this area here, so some of the shared questions are like outcome at the hospital. So if the EMS agency or crew documented deceased at the hospital, which many do. So if they bring a patient in and they see the hospital terminate while they're still there, many will document that, and then we know the outcome is deceased. So that's how we got this group here, the 307, and then this 403.
Okay. Is there an opportunity for to go back and correct EPCRs? If agencies are collecting their own outcomes, is it possible to go in later and put those in without a penalty for resubmitting data? Or does it have to be done all at once?
No, I believe, so I don't misspeak, Anne, I'm gonna put you on the spot, but I believe that is a yes, but I will have you answer that if you don't mind.
Okay.
Yeah, sure. So, and that's an excellent question. So there's no penalty later or anything like that. Occasionally when validation or business rules change, resubmitting will cause that to rerun, but usually those are limited by dates. That doesn't generally happen. So yeah, no, your initial submission is what counts for your timeliness.
Okay.
Resubmissions do a different date population, and we actually would encourage you if you have additional info, especially for things like this, because it's something that, you know, even if you're giving something that you found out from January of 2025, that data has not been run completely through share. So it would absolutely be beneficial to resubmit those. And I'm happy to help anybody with questions.
Yeah. Okay. Yeah, I was just curious if it incurred any kind of penalty for the agency, but thank you.
Thank you, Amber. Any other questions or comments about the share dashboard? And then I think the few other items on the Bureau report are available, just point of contact for enforcement or certification questions. I get asked that quite a bit, so we did want to make that available in the Bureau report as well. We will move on down the agenda to our standing committee report. I will go ahead and do the CHEPI report for Dr. Augustine, since she's not here. CHEPI, we really talked a lot about share, kind of the conversion from CEDAR, which was the old hospital database, to a REDCap process. And then also Anne had presented slides on the EMS data for out-of-hospital cardiac arrest and the Premier EMS Agency program. So we are really starting to see improvement in some of our data accuracy with that. And then Vaughn had also presented some of our 2024 EMS data dashboards. Jason, would you like to cover education?
Sure.
Thank you.
So we met and we approved the STRs for RSI training. And then we approved another work group to refocus on the EMT and paramedic scope of practice and 911 response for the draft of the CYSHCN training. That's scheduled for October 8th at 10 o'clock. And then we approved another work group to make STR training modules for the EMT ID STRs. And that one is scheduled for October 2nd at 10 o'clock. That is it.
Thank you. Next, Josh, would you like to do a PMD update?
Yes, absolutely. Thankfully, the PMD update can be very brief because we are going to talk about every single item discussed at PMD later on the agenda today. There was no other items discussed, so I think I'll end my report with that.
All right, thank you. And next, Adam, are you able to give a PACES update?
Yeah, hi, sure. Let's see. So at PACES, there was presentations concerning pediatric drowning data, high-risk perinatal program information, and AZ complete health crisis system information. A work group was approved to be formed to review the Department of Education's Red Book, which is their manual for lay persons at a school and contacting emergency medical services when necessary. So they asked us to review that, and we held the first of those work groups, and we'll be scheduling the second soon. And our members updated us for current issues in their areas. And our next an agenda item we're exploring for November is pediatric behavioral health. And that's it for PACES.
All right, thank you.
Thank you.
All right, we will move on to our discussion and action item. Can I get a motion to discuss, amend, and approve the meeting minutes from May 8th?
So moved, Frank Walter.
Thank you, Frank. Can I get a second? Thank you. All right. Yes. Are there any recommended amendments to the meeting minute? Hearing none. Any opposed? Any abstention? All those in favor say aye.
Aye.
Thank you. Next, can I get a motion to discuss, amend, and approve the draft CTTG for maternal hypertension, preeclampsia, and eclampsia? Thank you, Jason. Can I get a second? Thank you, Eve. All right, I will give a little bit of a background on where this came from. So this has been kind of a big national project to help decrease the mortality with maternal hypertension and preeclampsia over the last several years. This has been getting quite a bit of attention at the national level. And most recently, NAMSP as well as ACOG came up with kind of a joint kind of statement on management of prehospital maternal hypertension, preeclampsia, and eclampsia. Based on those documents that came out, PMD spent quite a bit of time looking at our current OB guidelines, looking to implement some of the recommendations from the national committees, as well as the medication recommendations for that. So I wanted to give a little bit of background about where this came from. Nationally, we do know that the United States is one of the highest rates of kind of maternal mortality amongst the developed countries. And so really, how do we address some of this? We know hypertension-related incidents are a big part of that mortality. And there's been a number of large, really high-profile deaths, unfortunately, involving some Olympic athletes. And so really wanted to spend a little bit of time going over this with some background. So this is the draft proposed maternal hypertension, preeclampsia, and eclampsia guideline. It goes through the inclusion criteria at the top, exclusion, kind of when to go to shock or childbirth. It has some basic interventions at the EMT level and AEMTs. And then it really gets into the paramedic section. And this is kind of the new section that we have highlighted here. And it breaks it down following the national document where it really talks about a little bit lower blood pressure threshold, but still high. So the systolic 140 to 149 or diastolic of 90 to 109 plus symptoms. And it lists out those symptoms. It says to give magnesium 4 grams over 20 minutes. Then with a higher blood pressure reading that is persistent for 15 minutes, so 2 measurements 15 minutes apart with or without symptoms. So this is the delineation that higher blood pressure threshold, even if asymptomatic, would still get treated. I know this committee spent quite a bit of time with PMD when we did our initial drug tables, and we went back and forth quite a bit on different blood pressure medications and ultimately ended up with them just for the critical care endorsement. Subsequent to this, the national position statements have come out. One of the key pieces in looking at this is, I think, the key part of this in the guideline is that 2 separate measurements 15 minutes apart. So if someone's in pain or they're anxious, you get 1 high blood pressure reading. That doesn't mean you're jumping on giving these medications. It's really demonstrating you have a longer transport time. And we do know that persistent hypertension in this patient population is associated with worse outcomes. So really highlighting that kind of prolonged hypertension. So for that patient population, they would still get the magnesium 4 grams over 20 minutes, and then treatment with antihypertensive agents. The 2 options that we have listed are labetalol and nifedipine. We would then get to the next category of patients, which would be a patient greater than 20 weeks gestation or up to 6 weeks postpartum with a seizure. And those patients, recommendation is the magnesium 4 grams IV. And then if there's no IV access, they can administer 10 grams IM in each buttock cheek, and it's maybe mixed with lidocaine. And then specifying for active seizure lasting greater than 5 minutes, not responding to magnesium, refer to seizure guideline and treat with benzos. So this is kind of matching the national guidelines for that. So this was kind of the new proposed guideline. PMD spent quite a bit of thoughtful time discussing it. Those of you that were present, I don't know if you want to weigh in or give any additional information about that. So.
Dr. Bradley, I'll weigh in briefly, simply to say that there was a lot of thoughtful discussion about this topic previously at PMD. I'll also weigh in from the National Association of EMS Physicians perspective, only to say that from a national organization perspective, implementing these guidelines at our level, a state Department of Health level, is incredibly important and supported by a robust consensus that we may be able to move the needle and at the very least increase awareness of maternal morbidity through these efforts. So I strongly support the document as presented, and happy to add any other comments if people have questions.
Thank you. Any other comments or statements for those who were part of that discussion, and for those of you that weren't, that wanted to ask questions or discuss? This is definitely our opportunity. Like I said, there's kind of a new guideline for the state. I anticipate that many parts of the state, if we approve this here today, will adopt something similar to this in their regions. So. Interested to hear kind of, I'm looking over to my northern and eastern counterparts in the room here. I think many, you have longer transport times and have patients that likely would fit into this region. So I just wanted to see input.
I think it's great.
Yeah. We did a look through to see how many patients it might affect. On a yearly basis, it's quite low, but there's no reason not to have protocol in place. So again, a lot of conversation that went into it. This is great.
Thank you. Dr. Walter, I see your hand up.
Sure, thank you. And I think I understand, and again, I applaud everybody involved. Well done. Just to make sure I'm understanding clearly, and that others will as they look at this, for the nifedipine immediate release, is it a bite and swallow or just to swallow the capsule? Is that going to be clear to the people doing this?
What makes a difference? Whatever you make your hands on.
I see some head shakes in the room saying not sure if it makes a difference or needs to be clarified, but do you have a thought on that?
No, I just, Josh, I just wondered from PMD what your intention was, or since it, are not concerned either way in terms of kinetics.
Yeah, Frank, I think that's a very good point. We did have a lengthy discussion about how individual medical directors may choose to adopt these. And I can only speak for myself and our group down here in Southern Arizona about how we intend to implement this. Kind of the discussion at PMD was an individual medical director, for one reason or another, may choose to use nifedipine or labetalol, or both of them. Here in Tucson, we're going to err on the side of selecting only one for exactly the reason that you highlight. Teaching a paramedic to administer labetalol or nifedipine is easy. They're very capable of doing it. However, the more drugs you have, the more likely we are to all make errors. So I think this is probably an educational pearl that should be included by an individual medical director when they adopt these guidelines. In Tucson, we'll be using labetalol. I think that's the direction we're headed. And so it would kind of be up to me as a medical director to include appropriate teaching for my paramedics on how to administer the drug. And I think for nifedipine, that would also include how to directions on how to take the tablet.
Okay, thanks, Josh. And
Hey,
I
Frank.
understand.
Hey, Frank, this is
Yeah,
Dan.
Dan.
Hey, do you have
Sure.
anything, do you have any, I always love to hear, do you have anything to educate us on there? Do you think one gets faster absorption? Is there, I always love hearing what you have to say.
No,
If the guidelines haven't specified.
yeah, no, and I appreciate that. And I just didn't know whether you wanted to preserve that flexibility, Josh, and it sounds like that. So basically, it would be the medical director of the specific EMS agency. And again, my only question was really on the nifedipine to either swallow or bite and swallow as they see fit. I'll take a quick look, Dan, to see. I don't want to speak off the top of my head and misspeak, but thanks for that vote of confidence, Dan. I appreciate it.
If I can maybe add in some color, there are several formulations of nifedipine available.
Yes.
Some should be chewed, some should not. So I think it's important that we leave flexibility for whichever formulation they do have. And I am a victim of Google, just as everybody else is. I did do a brief Google search. And it just confirms that there are multiple types of tablets available, and you should follow the instructions on the package. So that may lend itself to including vague language here that allows flexibility.
And the Amber, your hands up.
Oh yeah, I was going to say something very similar to Josh. When I talk to the medics in my agencies, the older medics remember the bite of the capsule and having to bite the capsule and then squirt it in their mouth. But I don't think any of the newer medics have any context. So I agree with everybody else in leaving flexibility, but I know some of our older medics remember biting the capsule open.
Any further discussion on this guideline? Vince, it was messy, but it worked. Thank you, Vince. So the motion on the floor is to approve this. I will start with, is there anyone opposed? Any abstention? All those in favor say aye.
Aye.
Excellent, that is approved. Thank you. Next on the agenda, if we can get a motion to discuss the matter to approve the draft table 1 to add labetalol for paramedic level authorized administration, authorized administration, I should say. Jason, thank you. Is there a second?
Adam going.
Thank you. All right, so this is just kind of in alignment with adding, you will see on page 3 at about just about the middle of the page, the additional labetalol, obviously optional agents at paramedic level. They had it for critical care endorsement. Any discussion? Any opposed? Any abstention? All those in favor say aye.
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 Can we get a few more ayes from the online people, please?
You do it.
Aye. Frank
Thank you.
Walter, aye.
Thank you. Right, next, item D, can we get a motion to discuss amended approved draft table 1 to add nifedipine for paramedics and critical care endorsed level?
I'll motion it then.
Thank you.
Mix it up a little.
All right. And you will see that in the next agenda, the next one is on page 3 as well, optional, and adding it for paramedics and critical care endorsements. Any discussion? Hearing none. Any opposed, please say nay. Any abstentions? All those in favor say aye.
Aye.
Again, my online people,
Frank Walter, aye.
thank you.
Stevie in favor.
Thank you. All right, next we have some draft drug profiles. Item E, can I get a motion to discuss and amend, approve the drug profile for Labetalol?
I guess back to me.
Back to Jason, it's the first.
Second.
Thank you. All right. The committee did spend quite a bit of time in the drug profiles. Frank, I am going to lean on you to make sure that we did due diligence with these. We really tried to keep these kind of specific for the indication that we have in the TTDG. So we understand there are other indications for Labetalol, but really wanted to highlight that for the purposes of this recommendation from our PMD and MBC, it is specific to maternal hypertension. So you'll see that the indication list is a list of one category only, kind of specifically for that purpose.
Just some questions, and again, it's really up to Josh's chair of PMD and the PMD committee and the wisdom of all of you on the call. Do you need to specify that this is a non-specific beta blocker? Is that going to make a difference to the audience that this goes to? And that's the reason for the concern with bronchospasm, et cetera, and the potential for unopposed alpha potentially. And then is the wording stimulant? I know it says example, comma, cocaine, methamphetamine, other stimulants. There's not a comma after the EG, if you like, but is stimulant the best word for this audience? And that's really my only thoughts on it. But again, overall, congratulations, well done.
Thank you, Frank. We actually did spend quite a bit of time on the TTTG next to Labetalol about the wording of avoided history of asthma, current cardiac or cocaine/methamphetamine intoxication. So I think, you know, we're open to different versions of that. I think the main recognition, typically this is paramedic students who are reviewing these as part of their paramedic training program. And then if an agency is adopting this, and so I don't know that they would necessarily care about the difference of the pharmacology, but I think the contraindication of the patients with asthma and then the sympathomimetic, are you thinking maybe a more broad sympathomimetic terminology, or do you have a different thought beyond?
I would say maybe I would favor sympathomimetic, but again, you got to bait the fish for the hook. You got to bait the hook for the fish you want to catch. And so it's really what you all think would make most sense to those less familiar with it. So, you know, stimulant is the right one, or sympathomimetic, you know, that would be my leaning. But again, I'll defer to the wisdom of the group.
I think as the fish, we did talk about the pathomimetic. We decided that stimulant was probably more broadly understood across the fish population.
That's great. I'm going to set the hook. Let's go with it.
All right. Amber, I saw you had your hand up, but it came down. Did you have something to add?
No, I was gonna say the same thing Matt said. We chatted about it when Dr. O'Connor had brought up the same point and had decided basically what Matt said.
All right.
See, that's what happened when you ask toxicologists.
Yeah. Well, it's a
Very
well-used analogy. So, well, now that we have baited the correct fish, sounds like, are there any other recommended amendments to the drug profile? I added the comma, Frank.
Yeah, no, sorry about that too. I apologize. What can I say? And then since nobody mentioned it, it sounds like it's not worth mentioning that labetalol is a non-specific beta agonist, but a specific alpha agonist too, for all the same reasons that you said, given the fish we want to catch.
Right. And Jason, and one of the things I've noted is you're right. The people who tend to ask are the paramedic students, not so much the seasoned paramedics, because they just are like, okay, labetalol, I'll use it. But this, honestly, when they read these things, when it's kind of written the way it is, it kind of opens the door for discussion, because then they'll say, well, what exactly does that mean? And gives you a chance to give a little education that way.
Sure. Great. No, thank you all very much. Well done.
Thank you. Hearing no further discussion, is there anyone opposed to the draft labetalol drug profile? Any abstentions? All those in favor say aye.
Aye.
All right.
Thank you. All right, next, can I get a motion to discuss and amend and approve the draft drug profile for nifedipine?
My turn, I'll motion. Thank you.
Thank you. Second from Jason. Thank you. Again, you will see under indications, we really wanted to keep this very narrow, again, with the goal being for specific one GTVG. So this is the proposed drug profile. All right, hearing no comment, is there anyone opposed to the draft drug profile for nifedipine as displayed? Any abstention? All those in favor say aye.
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 Hi.
All right.
Next is discuss and amend and approve draft update to the TXA drug profile. Can I get a motion? Thank you, Jason. Thank you, Steve, for the second. All right, for some reason, our onset and peak effects have gotten a little bit screwy on this one, so I did want to make sure we take some time in this. We had, I think, some incorrect times on this, so that was really the only proposed change. Shelley and I both tried to figure out what we voted on at PMD, and honestly, we could not figure it out after that meeting. And somehow that was my one paper note that disappeared. So I know we needed to update them, but wanted to confirm that onsets and peak, both of those for TXA.
For what it's worth, this does seem familiar from what we discussed. So I think you nailed it.
All I have remembered from that meeting is it is a range of 1 to 2, not to exceed 2. There was much discussion
Yeah,
about
that was,
just
yeah,
1
so-
or 2.
yeah, that was big, that was what the, that'll be the next
That's
guideline.
what's done now.
That'll be the next guideline, next discussion. I think we got really derailed on that, but, nicely derailed, a little derailed in that one. But we do have the onset and peak, which is a little, so Frank, I will weigh in on your expertise. We have a peak that is potentially shorter than our onset.
Thank you.
And thank you. It jumped out at me without the highlights, but the highlights really make it jump out. I'm jumping on Drug Bank now, which is my favorite kinetic site. So I'll double check it and put it in the chat. And then also regarding all the different formulations, I think it was really important in the initial guidelines we looked at, that we said it was non-extended release nifedipine. Was that also in the second document we look at, the non-colored one, the one we just looked at?
The drug profile does say immediate release at the top.
Okay, so they're both immediate release. Okay, yeah. Because when you look, there's over 130 some, or there's well over 100 different formulations, but maybe about 10% are immediate release, most extended. So let me look at drug bank and I'll respond shortly. So I'm going to hold you up, but I'd rather get it right for you for thromboxane.
Why don't we maybe, can I?
I'm
do
sorry for
some-
tranexamic acid. Yeah.
No, you are totally able to step on the brakes a little bit. And what we can do is maybe just quickly table this one. If I can get a friendly motion to table, we'll come back to this one and go to the next.
Move.
All right. Thank you.
There's a friendly session.
Currently motion to table that. We will just go down to the next agenda item, right? Oh, voted on. Oh, crap. Okay, can we vote on tabling that for 5 minutes and coming back? Anyone opposed? Any abstentions? All those in favor, say aye.
Okay.
Thank you,
Yes,
Shelley.
aye.
She will keep us out of trouble. All right, we're going to skip to item H, which is discuss and amend approved draft updates to the childbirth TPTG. Can I get a first motion? Thank you, Eve. Second from Jason. Highlighted here, we have a few additions to this one and a little update. So clarified, you can see highlighted at the top, sorry, back up there. Just for hypertension or here, we are linking them to the maternal hypertension preeclampsia and eclampsia guideline. If you scroll down to near the bottom, you will see TXA. We just clarified within 3 hours of birth. We did not have a time on there previously, because we just added in the time frame. And then for active seizure, again, refer to maternal hypertension, preeclampsia, and eclampsia. This section previously had all the magnesium wording, so that has now gotten moved to its own full guideline. So that's kind of the big change. Is there's that whole chunk on hypertension plus symptoms, and that was where we had magnesium. Now that it's its own guideline separately. So pretty basic changes to this one. Any questions or recommended amendments? Hearing none. Any opposed to the updates to the childbirth guidelines? Any abstentions? All those in favor say aye.
Aye.
All right. Thank you. Next, I get a motion to discuss and measure and approve the draft updates to general trauma TPTG. Thanks, Jason, for the first. Second for Eve. Thank you. To give a little background, we have robust discussions regarding this. Would be a good way of describing this, and really specific to the TXA dosing of do we move this to 2 grams? I think there were some in the room that really felt that the data supported 2 grams. There were a few people that felt very against how it was recommended. So we decided to simply leave this as 1 to 2 grams. And then we also realized that we needed to clarify a little bit how the pediatric range worked, because the way it was worded currently is a little bit goofy. If it was 15 mg per kg, could you go up to 2 grams? So we just separated that out as 15 mg per kg to a max of 1, or 30 mg per kg to a max of 2. So that is a little bit of background for those of you who are participating in that conversation. I know there were definitely varying opinions on that, so happy to have those shared today. And we kind of, this committee ultimately decides what the final dosing will look like.
Anything specific to that? I know some people are looking at certain data, and I think just going back and forth, having it, the option of both allows people to just stay consistent with what their trauma program wants.
Any other conversation for those of you that were on PMD and involved in that? So really just a kind of a minor edit for the pediatric one, just clarifying that's the weight-based, the appropriate weight-based max. So.
I'll only comment that this does align with the NAMSP and ACS-COT guidelines. It uses almost the exact verbiage in theirs that says EMS agencies may administer either a 1 gram IVIO dose followed by an infusion, or a 2 gram IVIO dose. So this would align us with the policy statements from those two primary organizations.
Thank you. Although it is interesting that they're saying following that 1 gram by the infusion of the 2nd gram.
Right.
Yeah, and on that note, it is funny. There is only one study that has evaluated this ever. And interestingly enough, that study showed that neither of these dosing strategies achieve effective serum levels of TXA. So there's really a lack of evidence in this area. It is clear, though, I should add, the 1 gram does have to be followed by a 1 gram infusion. It can't be given alone.
So I think that it's a piece of, ensuring when patients go to a trauma center or a non-trauma center, potentially, are they going to get that 2nd dose? I don't think that you get that from the current verbiage, because really what we are assuming is that once that initial dose is given, that they will get to a facility that will then give the infusion of the 2nd gram. So I think that part is really not on here.
Right, I think,
if that is
if I remember,
national
part
statement.
of it was because not everybody has a pump, so like to actually monitor the 2nd gram going in. So, they're supposed to though, like any transporting agency, I don't like a
Yeah, you
911.
don't have a pump.
Oh, they're not
You're right,
required.
sorry.
Yeah, you're right. 911 response. They just give a gram bullet and then go to the ER.
I don't know if anybody I haven't heard of anybody using a pump with it. None of the slight companies that
No.
typically give, if they're given the gram, they put it on a 60 drop and run it in over the time frame. So
I guess that is a discussion, because I don't think that piece came up at PMD for the discussion in terms of if they get 2 gram bolus, then they're getting a 2 gram bolus, and they're getting that complete dosing regimen. The current verbiage really is 1 gram, and then we hope that the hospital gets the 2nd one. Josh, I see your hand up.
I just wanted to clarify the exact language in that position statement is a 1 gram IVIO dose parentheses followed by a hospital-based 1 gram infusion over 8 hours. So you could consider inserting that language. This would be essentially 2 bullets, 1 gram pre-hospital followed by 1 gram in the hospital. 2nd bullet, 1 gram pre-hospital bolus.
Or 2 gram pre-hospital bolus.
Sorry, yes, that's correct. I misspoke. 2 grams.
Okay, yeah, okay.
So this is Dan, the usual stick in the mud. It's really interesting to hear all our detailed and very sophisticated conversation about the dosing for a drug that we have so little evidence about given this setting. Does that not bother anybody else? It's okay if it doesn't. I've just been, as you know, I've been bothered for 30 years about how much we do in the pre-hospital setting. Is it as the train left the station, so we might as well argue about dosing.
I'm not sure if we should, I think we should leave, well, for the peds dosing, I feel like the adjustments are fine. I think for the adult one, I think we should leave it the way that it is. The individual medical director is going to pick what they want. I don't know if there's any benefit to writing and 1 gram to be given in hospital. Like none of our other protocols talk about in hospital treatment. So I don't know if that's very beneficial. I think we should just say 1 or 2 gram bolus for the adult side, because it's not a range. So it shouldn't be 1-2, we wouldn't give like 1.1 grams.
Good point.
Yeah.
We have 1 or 2 gram.
1 or 2.
It's just a question, that affects what hospital they can bring the patient to.
No, I think even the critical access hospital, they all have TXA. I'm thinking like Streeterville, a place like that. So,
Yeah, I think we just leave it pretty generic, and then the individual medical director chooses whatever they want.
So the recommended change in, we can highlight the or. So thank you. I think that's is a nice, the way of potentially addressing that. And then I realized we don't have routes there. We should have routes.
oh,
Yeah.
yeah, IVIO.
I think.
IV/IO.
That would probably be the same on peds too. Yeah. That might be my own, yeah.
Hey Gail, it's Shari. Do you guys need
Yes.
a time frame on it? Haven't all the studies been like over like 10 and or are you guys really giving it IV push quickly?
I think in the trauma centers, most of them are giving it quickly.
Yeah.
Or okay.
Amber, I see your hand up.
Yeah, we've discussed this a little bit before. When you look at the literature, there's a theoretical risk of hypotension if given as a push, but most of the studies did not show that people were really experiencing hypotension as a result of a rapid push. So I think most of our agencies down here are using a rapid push.
Thanks.
Okay. And we did discuss that. The trauma centers are pretty much the same as well. They're using it. Okay, so the recommended updates are highlighted in yellow here. So any further discussion on this? All right, hearing none. Is there anyone opposed to the updates to the trauma management guideline as shown? Any abstention? All those in favor say aye.
Aye.
Frank, are you by any chance ready for us?
I'm back. Here I am.
Okay.
So
we
I've always
have
been
to
here,
do-
but yeah, just looking
All
at things. Both Daily Med, which is a standard we'll all be held to from National Library of Medicine, National Institute of Health, Drug Bank, started out at U of Alberta and really good for kinetics. Stat pearls, things like that, really don't speak about time to onset and time to peak, quite honestly, for TXA, for tranexamic acid. I just also, and because of that, and really you'd have to ask, how would you know that? Time to onset, time to peak. So I just called and spoke with our emergency department pharmacist, and again, looking at LexiComp and other things, really not an answer there. So unless there's good data from PMD that you had for time to onset and peak effect, which would be great, please educate me. And Daniel's looking into it further and looking at primary literature. He's also looking at double checking the nifedipine bite and swallow versus just swallow for immediate release. But my thought would be I wouldn't have time to onset and peak effect. They at least ought to be the same if they're correct, or we probably ought to double check this. Did you have a primary reference on the PMD committee for these? Because it's logically inconsistent, as you say, which is why you highlighted it.
So I can pull up what we have in our current. Why don't we take a motion back to address that? Can I get a motion to discuss the amend approved update to the TXA drug profile? First and second in the room. So first, Jason, second Eve.
What about if we just made it variable? We've been kind of generic, unknown or unclear, or, just leave it. If it's not clear, it's not.
You could say unspecified. Yeah, because also, for those of us using it locally, it works fairly rapidly. But again, having that systemic effect, and again,
The current version we had was an onset of 5 to 15 minutes, and then we had a peak of 1 to 2 minutes. And so I think what was initially brought forward was that the onset should have been much more rapid, the 1 to 3. But neither of those really, in my brain, makes sense with the peak being shorter than the onset.
I was just gonna say what I found online was the onset was 5 to 15 minutes, but peak effect was at the time of infusion completion. So if it was over 10 minutes, it was a fast push after.
And it really depends too, and it's unclear in my mind, and maybe it's because we're baiting the hook for a fish, but in times onset and peak effect are dynamics. What what the medication does to the body. Whereas Cmax, the maximum concentration is, really at the end of the infusion, right? Because you're putting it right into the vein, oftentimes or usually, but then it takes a while to work. So maybe we're mixing apples and oranges here. The onset to, inhibit clotting problems is going to take a little longer than the maximum concentration. Yeah, so it's not clear to me. I don't have an answer for you immediately right now, and it depends what information you want to convey.
I don't know if we're maybe overthinking it too, like, not just say either unknown or rapid. I mean, at the end of the day, like it's not going to change the way that the provider is going to be administering.
Yeah, I think rapid would be a good. I would second rapid for both.
I like that rapid.
Yes, I like it a lot.
If we add a berry,
Veritably rapid.
I think just one adjective is plenty.
So it would be rapid for both onset and.
Yeah, I think that's a really great suggestion. Thank you.
Then, I guarantee you it will take 1.2 days before I will get asked why the committee could not come up with a definition. I would think, because there isn't one.
If Daniel calls me back with a good source and good numbers, I'll be happy to let you know.
All right. I think that is probably a good compromise of where we have it. All right.
Edit at some point.
Yes. All right. Okay, so now we've updated these both to being rapid. Duration is unchanged. Is there anyone opposed to this current verbiage? Any abstentions? All those in favor say aye.
Aye.
Very aye. Sorry.
Thank you. Let's see, the next two items I actually got ahead of myself and have already kind of covered both the share dashboard and the 2024 EMS dashboard. I am happy to recover those if anyone has come up with any questions since we looked at this initially, but I think we've spent quite a bit of time on these. So if you have questions afterwards, suggestions, the really nice thing about the dashboard is that lots of can make changes easily. So already from the changes that were requested out of SAB and recommendations, she has already made the changes and we'll get those updated on the website. So happy to cover anything, but I think otherwise we've adequately discussed the Vision K. Hearing nothing from anyone online either. Agenda items to be considered for the next meeting. Does anyone have anything they would like us to cover? If you think of any items, please reach out to either myself or Shelley. Call to the public. And upcoming events, there are a number of upcoming events on the agenda here. You will see on December 3rd to 8th, there is the Cardiac Arrest Survival Summit. This is a great opportunity to really highlight all of the work that Arizona does in regards to cardiac arrest care. Our next meeting is January 15th at noon here, both in person and virtual. And if I can get a motion to adjourn, please. All right.